I want to welcome everyone to part 6 of Dr. Elorriaga's neurofunctional treatment of pain disorders. If you haven't been able to join us for parts 1 to 5, they are available on our website. So you can catch up and see if you have any questions, and please send us your questions, or if you get a chance to ask some questions today, please type them in the Q&A below, and we will get to them at the end of this week's presentation. So that being said, I will hand it over to Dr. Elorriaga, and I'll be back later. Thank you.
Thank you, Celine. I'm very happy and very excited to be here today to hopefully complete the first general overview of the neurofunctional approach to acupuncture, which is the approach I practice, I teach. I've been teaching for over 30 years, which has proven to me and the people taught by me to be superior to any other approach, paradigmatic approach particularly. And it makes sense because it's based on a superior understanding of the problems that we treat, and superior understanding produces superior solutions to the problems. And that's my goal here, to help practitioners listening to this series to embrace a higher level of complexity in what they do, to understand the multidimensional nature of pain with movement disorders, and then to learn how to optimize the use of this fantastic tool that we have, which is the acupuncture needle and the electricity. I'm going to start sharing the screen, and as usual, not sharing. Are you seeing my screen? Here it is. I believe that you're seeing my screen. And this is the last secret that I stopped explaining halfway through secret number 7, which was about target selection, which is the name of the game. And the presentation of that neurofunctional integrated approach, particularly the neuromapping and other aspects of the neurofunctional operating system, that I will, as usual, review. Also, I had a very good opportunity to present the main forgotten task of the body that's at the core of most clinical problems that we face, which is the force management system. And because it's an invisible and silent function, but is inescapable, as the body is under miscellaneous forces, particularly gravitational pull and reaction forces from movement, and the kinetic energy generated by these forces needs to be dissipated, as it cannot be destroyed, and is dissipated in the form of heat. That's a minor way of getting rid of kinetic energy. Continuation of movement, follow through, that is more important. Transfer energy to an object, that is very important. Tennis ball, golf ball, javelin. And the main mechanism that is relevant to us, that we should evaluate clinically, is how the tissues who suffer deformation, elastic tissues suffering either compression, tension, those are the main handlers of kinetic energy. We talk about the foundational microstructure in the body that takes care of this game of forces, which is called biotensegrity. And we explain that extends from the cytoskeleton to the fascia. We talk about the fact that the movement variability in the joints, more freedom and more ability to adapt to the directionally, as well as the involvement of deep muscles were two factors that improve greatly the management of reaction forces. And I explained briefly the process of neuromapping as the discovery of neurological and soft tissue dimensions of the complaint in order to produce a map that will integrate gross vectorization, meaning simply understanding which directions in the force handling are mostly not doing their job, and that's why certain tissues get overloaded. And also we integrate this with the map of the tensional behavior of the soft tissues and the movement capabilities and the mechanosensitive areas, the trophic changes, and the neuromotor behavior. I also explained briefly how movement analysis is mandatory and it has to be done based on a good foundation of biomechanics, muscle physiology, and involves also one neurological testing that we didn't represent, but we will do in the practical cases, which is neuromotor recruitment test and neuroreactivity, and also the palpation, detailed palpation of peripheral nerve pathways that leads to identifying nerves which are sensitized and parts of the system where the vascular system has produced plasma extravasation. And then finally, at the end of the presentation, we talk about positive adaptations that may help improve these force management abilities. And that includes architectural changes in the bone, in the muscle, in the connective tissues, enzymatic changes, metabolic changes, and neuromotor changes. And then we also have negative adaptations, negative adaptive responses, not adaptations, that occur due to insufficient energy availability, lack of perfusion, or very common neuromotor inhibition, failure of the motor system to access the muscles, particularly the deep muscles. And finally, we stated that target selection for needle insertion is best accomplished using an integrated neurofunctional approach, including this detailed structural neurological analysis of the existing adaptations to the habitual force management demands. This, in a way, oftentimes I tell the patients that what I do is akin to archaeology, because I try to figure out, based on these findings, what was there before. You find some remains of a city, and then you try to imagine how was the city with the buildings fully built, how was life in such a place, etc. And the final statement I made in the last presentation was that restoring adaptability is a superior treatment approach versus simply doing pain modulation. And to restore adaptability is mandatory that you understand how the system operates, because otherwise we cannot restore what we don't understand. All right, so that was the the summary of what we did in part 5. And as part of the mapping of the adaptations and whatever else is going on, you also need to understand all the factors that are going to influence the signals that eventually the brain is going to use to generate the pain experience. And these categories of contributors are well explained in 3 articles I wrote that you have access to in my LinkedIn and in the McMaster Acupuncture website. 3 articles devoted to explaining these factors. And I'm not going to review them today. I just invite you to read them. And in the future, maybe we can have a session just explaining or talking about this, because there are many clinical applications or clinical insights that can help us handling a practical case. When you look at this is an example in the diagram of a possible symptom felt on the elbow, and the numbers are in every area that could also be contributing to that pain experience, and that includes from local nociceptors to posterior primary rami at the segmental somatic, at the segmental vascular sympathetic, at the anterior primary rami at the sympathetic fibers that are on the anterior ganglia, prevertebral ganglia, like the superior middle cervical ganglion or stellate ganglion, factors affecting the kinetic chain, visceral factors, miscellaneous soft tissue related, central nervous system factors. So with all this, then, and the study of the neurofunctional levels of organization, you can then navigate the complexities of a clinical presentation where you're going to have to discover what peripheral nerves, what dermatomes, myotomes, sclerotomes are involved, what territories, and for that you have to track these nerves, starting from the area of the symptom, but also evaluating the whole kinetic chain, that sometimes you're going to find things away from the symptom area. For instance, oftentimes you have a hip issue and you're going to find tenderness, sensitivity on miscellaneous areas on the lateral aspect of the talocrural joint, the sinus tarsi entry to the subtalar joint, and even the territory of the superficial fibularis nerve. And if you work there, you will see changes taking place proximally, changes in movement capabilities, changes in intentional behavior, and that would challenge your beliefs in a structure, because you will see that lots of the things that we observe in clinical practice are neurally or neurologically driven. So just briefly, I invite you to review the nervous system from its original organization and segments to all the categories, anatomical, functional, that I mentioned. So briefly, because this, again, this would be another whole different presentation on the levels of neurofunction. So just as a reminder, the body of mammals is evolved using a segmentation that is remained as organized in principle. So from the embryo, things develop organized in groups, and the nerves and the cells that later on will form the muscles, the skin, come together from each given level. Obviously, they are the levels of the brain stem that corresponds to the cranial nerves, numbers 1 to 12 in humans, and then the spinal cord attached, connected to the brain via the brain stem, which also has 3 divisions, and then the spinal cord has its 13 cervical segments, 12 thoracic, 5 sacral, 5 coccygeal, and 1 extra. So important to understand one anatomical relationship, which is the difference between the segment in the spinal cord and the spinal nerve of the same name that exits usually much lower as we go distally, much lower than where the segment is. This is important because it generates two reflexogenic areas. So the spinal cord ends up at L2. Therefore, there is no spinal cord at L3, L4, L5, S1, which means that those 30 something segments that I mentioned before, they need to be formed and to give birth or origin to all the spinal nerves, which means that near the end of the spinal cord, so in the area of T10, L2, there are more segments than in any other area. So that area is more reflexogenic than any other area in the body, particularly in the territory of the posterior primary rami, T10, L2, because you are affecting anything that goes from, let's say, T10 to S5. So that would be 2 thoracic, 5 lumbar, 5 sacral, that's 12, and the coccygeal. So 13 levels in 4 vertebral levels. And also is very reflexogenic because the innervation of the suprarenal glands is in this area, and is a very highly sympathetic or reflex area as well. So that's an important detail in order to select inputs. This is like the highest real estate on the back, C7 to T3 and T10 to L2 for this reason. Then you can also combine a stimulation or neuromodulation at different levels. You can go to the level of the exit of the spinal nerve, which will take place at the level of the vertebrae that carries that name. So even though the spinal nerve exits the spinal cord, let's say L5, at the level of T12. However, that nerve has to go down 5 levels to exit at the corresponding foramen between L5 and S1. So you can modulate L5 nerve activity at the L5 vertebral level, but also at the T12 vertebral level. And this is a principle that's applicable to every nerve, not just the spinal nerve, but peripheral nerves as well. You have to learn how to access these nerves at different levels so your message arrives at the neurons that you're interested in modulating. So these are some practical details. You need to have a good map of dermatomes, myotomes, sclerotomes. Not all maps are accurate. This one is, where you can see that there is no C1 dermatome. There is C2, C3, which are correspond to the occipital region and base of the neck. And then after C3, C4 is the first one that goes down, and indeed C4 is the predominant dermatome on the shoulder, and there is no C5, C6, C7, T1. It jumps from C4 to T2. These anatomical details have relevance because the C4 dermatome is delivered via particularly the supraclavicular nerves, cutaneous branches from the cervical plexus. And if you know where the supraclavicular nerves exit the neck, which is at the level of the laryngeal prominence, posterior border of the sternocleidomastoid, that's called the Erb's point in ENT, ear, nose, and throat a specialty, and if you know that, then you can access that point to modulate activity in the whole dermatome. That also coincides with the traditional insertion site, small intestine 16. So knowing the exact location and best access of the nerves is the greatest power that you can have as practitioner, because the selection of the insertion site will be more accurate and will have higher functional significance and likely higher clinical effects. It's important also to understand the double arrangement of the spinal cord, anterior and posterior horn. Posterior is devoted to the sensory neurons, anterior to the motor neurons, the types of motor neurons, alpha and gamma, the many types of sensory fibers. The body of those fibers lives in the dorsal root ganglia, and then how the arrangement between the ventral root and the dorsal root creates the spinal nerve that then it divides into anterior, posterior, primary rami. Each of those subdivide. The posterior subdivide into medial and lateral, and the anterior between anterior and posterior. And then the sympathetic fibers are integrated into this spinal and peripheral nerves, except the ones that go to the viscera, that they have their own anatomical existence, such as the greater splanchnic nerve, etc. All this is fundamental knowledge that is going to help you, at least in your brain, track the flow of information and better understand possible interactions of the information at the spinal cord, and then you can try to manipulate that by going to relevant afferent pathways that will lead to that segment. So segmental diagnosis is a very important part of the neuromapping. Obviously, the anterior rami, to know exactly the plexuses, where the nerves come from, which ones have anterior divisions of the anterior rami, like the yellow here, or posterior division of the anterior rami. Posterior divisions, remember, that go to innervate what's behind, which is the extensor side, while anterior divisions of the anterior rami go to innervate the things that are in front, which is the flexor side. So in this case, the femoral nerve, as the leg is like an arm, but that has been twisted, so the thigh really is posterior, and the hamstring area is anterior, or is innervated by anterior divisions. Again, knowledge of anatomy, embryology, functional anatomy, comparative anatomy is always useful at many stages of the process of analysis and deconstruction. We can use that word, deconstruction of the dysfunction. What I beg you to stop is thinking single problem, single structure. There's no such a thing. It's complex, involves many levels, and it's better to find these segments, these spinal segments, spinal nerves, these peripheral nerves, not just singular nerves, but the divisions. Is this a problem on the extensor side or on the flexor side? As this anatomical organization, this anatomical organization is very connected to the functional dimensions of the locomotor system. It doesn't hurt to know the types of fibers and to understand the functional differences, which here in this table I plot the different correlations between fiber diameter, velocity of conduction, type of fiber, where those fibers are found, and all this is on the motor side, and then the corresponding sensory fibers, and finally, what innervated the structures. So when you study this, you can see that we have fibers that are 20 times faster than others. The A alpha fibers are 20 times faster than a C fiber, which is very significant. That's a 2000% faster. So 120 meters per second for an A alpha fiber, which is a normal motor neuron, alpha motor neuron, versus 2 meters per second. So on an NBA player, a tall guy, the pain experience on the ankle when suffered the sprain takes at least 1 second, the 2 meters, 1 full second to arrive at the brain, and maybe a little longer to become conscious, versus the fraction, so 2000 times, 120 times faster, 2000% faster for a motor signal. Equally, mechanoreceptors are very fast, particularly the ones that control most closely movement, which are the muscle spindles and the Golgi tendon organs, and which corresponds also to thick myelinated fibers, which end up on specific receptors like the ones the 1A, 1B, corresponding to the spindles. And when you descend in speed, in my opinion, nature is telling you something, that the functions associated with the slower fibers are not as critical. So the fastest is motor recruitment. You need to contract the muscles as fast as possible. And the sensory, the exteroception, the proprioception, because you need to control that movement at equal speed. So that's where the fastest fibers, both on the sensory and the motor side, are. Then, when you are dealing with information that simply tells you something about the environment, is it cold, is it hot, or there is any threat for the tissue, pain, this appears at a much lower hierarchic level, meaning signals that move much slower. Indeed, we have like two kinds of pains, the fast pain and the slow pain. The slow pain is the one from C fibers, which is the more the dull ache, and the fast pain is the one associated with A delta fibers, which is more the prickly, sharp. And that also, the A delta obviously are mechanonociceptors. They handle information from potential danger, but also from movement. While the C fibers, most of the C fibers just deal with nociception that will end up in pain and temperature. So study all this, study the different information is packed in different groups of axons. We have two main ones. The nociceptors are going to cross the midline once they enter the dorsal horn. Interneurons are going to transfer. They're going to integrate the signals. They're going to modulate the signals already, and they're going to pass it to the contralateral side, and that's going to form the spinothalamic tract that's going to go all the way to the thalamus, and then from the thalamus will be sent to different parts of the cortex. While information that's not nociception, proprioception, mechanoception, will not cross the midline at the spinal cord, but will continue up via this area of the white matter, which is called the dorsal column nuclei. So dorsal column nuclei have the proprioception. And when those signals reach the medulla oblongata, already above the spinal cord, then they will make a U-turn, almost. No, it's not that true. Well, a little bit of a U-turn that will take the signals to the other side. Actually, this decussation of the medial lemniscus is being compared to a knee, the shape of a knee. And then from the thalamus, again, the information will be spread out in different cortical regions. So it's very different, the pathway, and therefore that influences, if anything, when you have a spinal cord injury, you're going to suffer changes on the proprioception on the ipsilateral side and changes in nociception on the contralateral side. Because if this side of this spinal cord gets affected, the signals that came from the other side get interrupted. So you suffer anesthesia on the contralateral side. And on this side, it will interrupt the proprioception, mechanoception, so you will suffer a loss of proprioception on the ipsilateral side. So spinal cord patients have this duality on the topography of the presentation of their problem due to this anatomy. This is the first map of refer pain that Henry Head, the English physician, which was at one point the head of the journal Brain. This is from the 1800s. So he collected cases where they would track the complaint of the patient, and then when the patient died, the autopsy will reveal an exact lesion, whether an aneurysm or a visceral problem, and then he would try to correlate the area on the skin where the patient was complaining of pain and the internal organ. And he developed the very first, is one of the first illustrations. In those days, it was very hard to create an illustration for a journal. So the journal Brain, this is one of the very first illustrations. And it is fabulous, fabulous work, because we learned, for instance, that L5 issues affected the lateral side of the leg, the outer side of the foot, which we know perfectly nowadays that this is an L5 distribution for a discopathy, for instance, and S2 would be posterior thigh along the hamstring territory, so on and so forth. So this learning came through many years of clinical observations and evolution in the recording and the investigation of pain problems. Also, you need to become familiar with the many segmental reflexes that exist, such as the reflex of reciprocal inhibition between agonist and antagonist and how it's wired, and the autogenic inhibition and muscle contraction inhibits itself in order not to overdo and then subject the muscle to excess mechanical stress. So all these segmental reflexes, they're very important, like the knee jerk. Some we test, they're tendon reflexes. These are muscle reflexes. And then we have other maps which correspond not to a specific anatomy, but they are a combination of peripheral nerve trajectories, refer pain, maps, and miscellaneous clinical observations. So the meridians could be constructed as such, as simply a clinical map, not as an anatomical reality. There is no anatomical reality, despite some attempts to do it. But it's clear that when you observe the traditional meridians, there is a significant overlap between peripheral nerves, particularly on the distal part, is absolutely 100%. So here the large intestine meridian follows the superficial radial nerve on this territory. The the master of the heart meridian follows the median nerve, and so on and so forth. And all these methods are useful if we put them in context of a model. So this is the last secret, secret number 8. And it's crystal clear for the, rather few of you who have endured these 6 hours that I've spent just painting the first sketch of the picture, that there are no easy treatment formulae. And that's okay to say, and that's okay to accept. We have a very difficult job because we deal with complex problems. The human body is extremely complex system. Therefore, we cannot use oversimplified, simplistic methods. Is not only inaccurate, but in my opinion, is unethical. Ignoring the complexity of reality is at the minimum is foolish, and at the maximum is unethical. So as I always say in my courses, if you dislike the complexity, then do something else. Fix bicycles. They're mechanisms you can really grasp and you'll be happy. Or be a plumber, because the complexity of the problems is very limited. The human body, on the other hand, has an array of problems that's infinite. And therefore, you need a methodology that allows you to navigate this complexity. And this methodology that I've developed over 30 years of practice, more than 30, is the neurofunctional operating system. So use it, abandon linear thinking, abandon oversimplification, and also play this game as a team sport. Taking care of people is a team sport. No one can have all the knowledge that is required to handle the hypercomplexity of the problems of the human body. Therefore, build a team. Build a team, meaning find the best healthcare professionals in your area and work for them and with them, and exchange patients and share patients. I find oftentimes that practitioners tend to be too individualistic, want to be the ones fixing the problem, losing sight of the mission. The mission is to help the patient. There is no room for anything else. So now I go back to the initial question, and I'm going to give the last 10, 12 minutes, then I'll leave room for questions. I go back to the origin. Where to treat? That is the question. And now we're better equipped to understand this, that pain with movement disorders are very complex. And that in order to localize the best places to treat with the needle, with the hand, with whatever, you need a detailed analysis, case by case, for both practical and ethical reasons. Or you'll forever be an amateur player, like chess. In chess, it's okay, but in clinical practice, it's not okay because people suffer from the laziness, incompetence of practitioners. We are faced with a terrible crisis on the pain management side, where many patients become pharmacologically dependent, and even though those drugs are not taking care of the problem, where we're generating additional problems of addictions and of other sorts. So we really need to become grandmasters to play the game, the clinical game. And for that, you need tools. I share with you some tools. I'm going to remind you. there's always the strategy part and the tactical part. But without the strategy, the tactical is useless. So if I teach you techniques to reach the subclavius muscle, the subscapularis, the popliteus, it will not serve you for the most part unless you have a way of putting it together with the analysis of the problem. So I think every case you see, try to review it and ask the following questions. What is the nature of the problem? Have I understood what really is going on? Is this more metabolic, neurological, biomechanical, behavioral? The pyramid of movement will serve you well for that analysis. Then review the key pain experience events. And for that, the pain puzzle will serve you well. I just presented that the tool exists. Obviously, that's like a 2 hours, 3 hours on its own study. Then review the clinical dimensions of the problem. So do a neurofunctional analysis, and that neurofunctional analysis should include also the main clinical events. I will review one by one now. And then finally focus on the part of the system that's doing this very high consuming energy task, which is force management, which is the main one, but it's influenced by the others because you can have the same needs, the same adaptive demands and force management when your system has normal levels of vitamin D, or when you have low vitamin D, and then that is going to create weakness in the tissue that could lead to injury, where someone with the appropriate amounts of vitamin D is not going to suffer that. So the analysis of one part has to be contextualized with the other part. So in a nutshell, the nature of the problems that we're dealing with could be, in a very long sentence, defined as the result of multidimensional neuromechanical, metabolic, cellular dysfunctions coupled with suboptimal adaptations of the connective tissues to gravitational and reaction forces, and not as a result of a primary macrostructural problem. This last addendum to the definition is very important because it denies the existing party line that most pain problems have a structural origin or dimension. I reject that idea, and I can challenge with data that idea. Most pain problems are not the result of primary macrostructural problems. That's why MRIs, X-rays, etc., are pretty useless for the most part to identify, even when they find something, because many times they find something, that something is addressed, and the pain problem doesn't disappear. Interesting. So then what happened? Is absolutely irresponsible nowadays to embrace that, even though that's the official medical model, the official orthopedic model, because evidence-based medicine tells you that numerous individuals walk the streets with numerous macrostructural problems that never cause a clinical issue. So a bulging disc is not a cause effect because many people have bulging disc and no problems. A little tear of the supraspinatus is not a cause effect because many people have those tears. 28% of autopsies show tears on the supraspinatus with no history of shoulder complaints. So it's very important. What I'm proposing, obviously, is not an evolution, it's a revolution. But the only way to change things is to be radical in the ideas, but always based on reality. I'm not presenting a viewpoint, I'm presenting reality as I've studied for over 3 decades. So here you have the pyramid of movement, which will help you understand a little bit, at least remember to look into all these dimensions. Start with the metabolic, neurological, obviously biomechanical, and behavioral. But the biomechanical is useless if you don't understand the neurological and the metabolic. Most problems manifest at a different level from where they are originated. I repeat, most problems do not manifest at the same level where they were produced. So many things look mechanical, but they're really neurological. Many things look neurological, but they're really metabolic. And this is very important. The clinical dimension versus the nature. You need to identify the nature if you want to be truly effective. The pain puzzle will help you organize your thoughts about events, peripheral events, spinal events, central events, and this is by far the most complex part, probably, of the equation. Then, the different clinical dimensions that here I've grouped in 4 levels: joint and soft tissues issues, peripheral and nervous system and spinal cord, central, supraspinal, and environmental dimension, and the rest, visceral, endocrine, autonomic nervous system. So these clinical dimensions have events that happen at these levels that you need to be familiar with. For instance, you need to be familiar with inflammation. But please don't call inflammation a pain problem. So when someone has pain over the greater trochanter, it's not trochanteric bursitis. If it's not red, if it's not swollen, if it's not hot, which is 90% of the time or more, it's not a bursitis. So don't say the person has trochanteric bursitis when you mean the person has pain over the greater trochanter, which is really a sensory neuropathy of the lateral branch of the hypogastric, iliohypogastric nerve. So in daily practice, there are horrendous clinical mistakes made all the time due to lack of good methodology, laziness, and neglect, really. Because if you look at the greater trochanter and there is no redness, there is no one sign of inflammation, why you call it inflammation? So don't talk about lateral epicondylitis, because I'm yet to see one in my career, and I've seen hundreds of lateral elbow pain. Is lateral epicondylalgia, lateral epicondylar pain. That's what it is. Most of the time, if you want to put it structurally, it's a tendinosis. And please don't mistake osis with itis. Osis means degeneration. Itis means inflammation. So in America, people say arthritis, which is wrong. People don't have arthritis when they have degenerative joint disease. They have arthrosis. I don't know what happened when ideas and words cross the Atlantic, because frankly, it's crystal clear, and a medical professional should never say arthritis when it's arthrosis. Most of the itis are autoimmune diseases that affect collagen tissues that are truly inflamed. Then rheumatoid arthritis, correct. But you cannot say knee osteoarthritis. No, it's osteoarthrosis. Anyway, it's very important to be precise, because it's really ignorant to use words in medicine that mean crystal clear one thing when it's not the case. All right, so I invite you to raise your bar, be more precise, study harder, and be above the rest of practitioners who don't do that. Events that you need to know very well involve transduction, transmission, modulation, amplification, which was the 11 factors I show you there, the reflex responses, neuroplastic changes. Each of those is a world. Central events, etc. It's not easy. And then there are models that could help you from the scar tissue, the healing mode, to the neurobiological model, which involves the understanding of the chemistry and other things, to the connective tissue directional adaptation model, also connected to the fascia model. So you need to understand the neurostructural metabolic dimension and the tensegrity model that is in every of the areas. And then you need to know the neurobiological model as well, the biopsychosocial model, the psychological, psychiatric models, the psychoneuroimmunology model. Of course, nobody can know this in depth, but you need to be aware of the multiple interactions between endocrine system, locomotor system, psychology, and general functioning of the body. And then you can access and should the most material part of the system, the locomotor system, and there you can study movement capabilities, tensional behavior, neurofunction of different levels, nerves that are sensitive, which indicate spinal or peripheral sensitization, and the state of the tissues. So that is the neurofunctional operating system in which you analyze, and this is what I presented in last lecture, number 5, qualitative biomechanical, visual analysis, then do a manual evaluation of movement capabilities, do an integrated evaluation of tensional behavior, neurosensory evaluation, so determine which nerves are sensitized, and whether that sensitization is qualitative or quantitative. Is there hyperalgesia or allodynia? It's not the same. Neuropathy is pervasive, but there are different categories of neuropathy in clinical practice, from what I call self-limited neuropathy of small nerve fibers. And that's, again, another topic for another master. And the neuromotor testing that will demonstrate someday, but not here today. So with all that knowledge, you'll be better equipped to answer and to execute the tactics, which is where do I put the needle, how do I put it, what kind of connection do I make, and for how long do I leave it, and then what complementary interventions do I add, and when do I repeat, and how do I measure the effects of my input. And frankly, prove me wrong. There is no other better way than to have clarity on all these dimensions. How is the nervous system? How is the force management? How is mobility? How are these kinetic chains operating? What's the metabolic state of the patient? And you need to do all kinds of tests, blood analysis, saliva analysis, urine analysis, stool analysis. We do all that with our patients, and rarely you need to do MRIs. That's the least useful, but sometimes you need to do ultrasounds for the soft tissue, you need x-rays, and the most you need is to do a thorough manual examination, movement capabilities, tensional behavior, neuromotor behavior. So this is it. This is a presentation obviously not conducive for you to be able to apply it, but so far I've given you the map of the territory, which is not the territory. I've given you a compass and ideas about how to use the compass to navigate the territory. So now you're going to be an explorer. Grab the map, grab the compass, and go to the jungle. And there you will face the realities. I mean, you already do, but if you start looking at things with this new perspective, you will recognize new things, you will notice things, and that will lead to refinements on your treatment, and that will lead inevitably to better clinical outcomes. So I'm going to stop the sharing of the screen and let Sulin be the master of ceremonies here. Ask me anything you want.
Thank you, Dr. Elorriaga. And thank you for the reminder again to keep improving our practice, our vocabulary, to be precise, to be exact. Does anyone have any questions for today? Again, if you haven't had a chance to watch parts 1 to 5, they are available online for now to watch. Please take a look through those, especially if you've come to part 6. We appreciate everyone for joining us today. If there's no
Yeah,
questions, sorry, go
if
ahead,
there are no
Al.
questions, I will um maybe try to give some guide to those who really want to improve themselves. And I will use my own example, not on clinical, but on the use of language. When I moved to Canada, first I didn't speak English. I didn't speak a word of English. And over time, I acquire a level of proficiency which exceeds that of many people who have lived there for more years than I did. And one of the differences was my approach to the learning of the language. Same thing you can apply to the learning of the clinical. First of all, it's not going to be linear. At times, you're going to feel even less competent than you feel now because you are going to exchange a certainty, which is false, but anyway, it's a certainty in your brain. You're going to be exchanging that for the reality. It's like an explorer who's read lots of books of exploring, but never been in the jungle. Then when you enter the jungle, second step, there's a snake, third step, there is a crocodile, and then you have to make decisions on real time that are not theoretical decisions, but real decisions. And nothing can be a substitute of experience. But this has been studied, and I'm a student of learning, acquisition of learning. The acquisition of anything, any knowledge, any skill requires what is called deliberate practice. Meaning, when you practice something, a language, music, a magic trick, you need a system of feedback in order to know how well you've done it. Because if you don't have feedback, you cannot improve. So what I did, every person I met, I said, I beg you, please correct me every mistake. I don't mind. Most people feel embarrassed or too polite to correct someone. And then after a while, the mistakes that people make, they get already ingrained, and then it's very difficult to change. So deliberate practice is the method. Meaning you can pay more attention when you're doing things, but also you should ask feedback from people who already know more, because having mentors, having a guidance accelerate the process of knowledge acquisition. So in this respect, the people attending these sessions have a fantastic opportunity with a database of presentations that the OP Supplies facilitates. Use it, but consume it as well, not in a casual manner, but listen several times, take notes, highlight the things that challenge you the most, go back to that, and then acquire additional knowledge that will support that. And that's how we all build whatever level of skill we may achieve in anything. Is a commitment. It takes long time. It took me a bunch of years, 5 years maybe, to say, okay, now I'm competent. I can communicate in English and sound as smart or not smart as I sound on my own language, which was my goal. And but I continue to study that to this day. I read, I do the Wordle every day. I've done hundreds of Wordle. I've learned new words. I learn new things. I listen to good speakers. I pay attention to good interviewers, etc. It's an active, never-ending process. So I would hate people trying to use this as a shortcut. Okay, let's learn a couple of tricks. And this is about a superior approach to learning, not about tricks or techniques. There is other forum where we can learn some things that, okay, they're exciting because everyone likes a good trick, but better than the trick is the understanding. So the power is in the knowledge.
So we have a question here. Organizing a treatment schedule can be difficult. Starting points can be challenging. How would you start with the huge significance of the metabolic component while doing manual procedures, including NFOs?
That's a very good question. And first, I would say when I started practicing, one of the things I did was I asked more time from my patients, but I explained why I needed more time, and they gave it to me because oftentimes I always was faithful to the process of collecting the clinical information first and organize. So many times I started 30 minutes sessions. I would arrive at the 30 minutes, hey, listen, we don't have time for treatment today. And nobody ever um, not came back because we hadn't reached the treatment. On the contrary, they said, thank you. You're the first one who's taking the time to organize that. You know how many times in my career I've heard, you are the first one. If you don't hear you're the first one, you're not doing a great job. I promise you that. So, oh, you're the first one who ever asked me this. You are the first one. And I noticed that, but I was doing what I learned and I was following just the steps. So shortly after, I said, listen, I need an hour because I take a good history, the first, and people didn't have a problem paying double and having a double session. So shortly after, I did an hour. And over the years, that hour became two, three. If you want to see me now, I need a minimum of 3 hours to really have the time to go through a good process of organizing information. So I say that practice models should be based on methodology of information gathering, and then the treatment part has its own. That's a different one. We can talk about parameters or you know. And I see my friend here calling that's asking, there's an order. Yeah, the order is always the same. First, seek clarity. I don't like to start treating until I understand what I'm going to face. And then the needles are is particularly good to prepare the system because they act as a cleaner, so to speak. When you do the needles, you normalize sympathetic activity. It's like you take noise off the equation, you improve perfusion. Therefore, you separate the presentation plus the stress of having that plus the negligence in treating it from what really is going on. So typically what you see is not what is happening. You see an amplification of it. So first I like to remove the noise. Then I go and start examining soft tissue movement, and then I focus on where my hands tell me that there is a major obstacle. Remember what we said, I think it was here in this presentation, so maybe no, it was in another context, but I'll do it. First treatment principle, the most important is remove before you add. Therefore, identify roadblocks, identify what's preventing the system from self-regulating, because the system is self-regulating. So if it's not doing it, it's because one signal is interfering. So if you're dealing with someone who's had an ankle sprain and they are having issues on the leg, on the lower extremity, typically it's because still to this day, months, years after the sprain, signals from the interosseous talocalcaneal ligament are reaching the spinal cord and blocking the normal flow of afferent-efferent. So the first thing you have to do is go there and remove. And how do you remove the signals? The needles help you because typically you need a chemical change, and the needles and the electricity and the hand as well produce a turnover at the local level that changes the chemical environment, which immediately changes the nerve activity. So first I try to clean the things that are in the middle, just to achieve clarity. Clean, remove. And this is so effective that sometimes when I'm done cleaning, removing, I'm done. So oftentimes when the people say, well, this is a question I ask, when do you start treating? And when do you stop treating? It's a very good question. And I will not answer the first one because that's another conversation, very interesting. But I said, uh, you stop treating when the system, the patient is ready to go on its own and generate adaptations that are positive. So for that, most of the time, if you just remove the things that are there, the constraints, the restrictions, the limitations, the neuromotor inhibitions, that's it. It's as if you had added, because in actuality, when you remove that, you let the system operate again at the functional level. So it's really empowering and non-stressful approach to treatment because you don't have to look for things, say, oh, I don't have this power. No, but you always can clean and see what happens.
That's excellent advice. Get people out of their own way. If there are no other questions for today, thank you very much for those. Then we will stop here until next time.
Thank you very much for having me, and we'll have some sort of follow-up once we figure out how and when. Thank you everyone for attending. Have a
Thank
great day.
you.